Today we will be discussing about Osh Mahotsav 3.0 Scholarship Test 2, which was on ENT and microbiology. In the first part you will get all the question related to ENT, and in the second part I will explain you all the question related to microbiology. So let's start. The first question is in ENT is 48-year-old man reports decreased hearing in the right ear for last 2 years. Okay, na? On testing 512 Hz tuning fork, Rene without masking, negative onto the right ear and positive onto the left ear. Weber test perceived louder onto the left ear. What is the most likely condition? Okay, na? So first I am coming on to the Weber test. Okay, na? Weber test we are using tuning fork and we are putting in the center of the head, and if person is normal he will hear equal sound onto the both side. Okay, na? So equal sound into the both side, or he will hear in the center of head. Next is person with conductive hearing loss, means he is having problem with external ear or middle ear, means conduction is the problem. So in the affected ear he will have lateralization of sound, means he will hear more sound onto the affected side, and normal side he will hear less sound. So normal side will be negative and affected side will be positive. Why it is happening? Because of conductive hearing loss, the affected ear cochlea will be hyperactive. Because of hyperactivity, they will perceive more sound. That's why it is lateralizing to the affected side. But in SNHL, sensory neural hearing loss, in this condition, patient is having problem with cochlea or problem with pathway, auditory pathway. Okay, na? So in this condition, cochlea is not working. That's why on to the affected side it will be negative, but on to the positive side it will be positive, means it is lateralizing to the normal ear. Okay, so this is for Weber. For example, I will take right conductive hearing loss and left sensory neural hearing loss. Right conductive hearing loss means which side Weber will be positive? Weber will be positive onto the left side and negative will be onto the right side. Okay, na? For SNHL it will be opposite, so it will be onto the left side it will be negative, and onto the right side or normal ear it will be positive. Okay, na? So this is for SNHL, but we will never rely on to the Weber alone. We need to check for Rene test. Okay, na? So Rene test can show us positive result, negative results, and it can also show us false negative result. So Rene test is done for the ear conduction. Okay, so we will check ear conduction is better than bone conduction or not. If it is more than bone conduction, then it is positive. Okay, na? So normal person can show this, or person with SNHL can also be positive for Rene test. It will be negative in conductive hearing loss person. Okay, na? So why it is negative in them? Because conduction is the problem. That's why ear conduction is not proper. So they will have negative Rene test. False negativity, when person is having very severe SNHL or dead ear, means which side of the ear is having very severe SNHL, that side they will be negative. Okay, na? So that's why it is false negative. So onto the same side the ear is not able to hear anything, or they are not able to perceive anything, so it will Weber will lateralize, or this Rene will be positive onto the other side. That's why it is it is shown in severe SNHL. For this also Rene test, whenever we are checking for sensory neural hearing loss, we are doing masking or without masking, means we are whenever I am checking the right side, I will put some music onto the left side, so there will be no crossover. Okay, now what our question is saying? So question is saying that patient is having Rene test without masking onto the negative right side negativity, positive on left ear. Weber is positive on left ear, so I will write down. Okay, na? So for Rene I will write down it is negative onto the right side, left side it is positive. Okay, and for Weber it shows it is positive onto the left side. Okay, na? So now if Weber is positive onto the left side, it will tell me only two things: either it is a left conductive hearing loss, or it is a right sensory neural hearing loss. Okay, then if it is a right negative, then it can be right conductive hearing loss. Okay, so now I need to check which answer will be more appropriate. Since in the question they have told us that it is without masking, means there will be possibility of crossover, and because of crossover of the sound, right side of the ear is having severe SNHL, that it is not able to perceive any sound, that's why it is negative, and Weber is lateralizing to the left side. So the correct answer in this condition will be right SNHL. Okay na? So why it is? Because if you will make a right SNHL table, okay, for Rene, usually into the Rene it has to be positive onto the right side also, positive onto the left side also. Okay na? And for Weber it has to be positive onto the normal side. Okay, so that's why this is the correct answer. Since onto the right side it is showing negative, and without masking means it is a false negative Rene test. That's why I came on to the answer right SNHL. So for this condition, correct answer will be right sensory neural hearing loss. Okay now, why not conductive hearing loss? Because if the patient is having right conductive hearing loss, okay na, in this case the Weber should lateralize to the right side, not to the left side. Okay, so but in the question Weber is lateralizing to the left ear, that's why conductive hearing loss is not the correct answer. Okay, and since they didn't mention severe, still we will think of sensory neural hearing loss because of the Weber positivity onto the right side. Okay, so next question is all are indication for procedure shown in the image except. Okay na, so this procedure you can see they are removing the tonsil. So this is tonsillectomy. So now they are asking what are the indications of tonsillectomy except, means which is not the indication. So here is the full list of indication. So there are absolute indication, there are relative indication. So in absolute indication, first is obstructive sleep apnea because of enlarged tonsil. This is the absolute, because if you will not really not do tonsillectomy, the apnea symptoms will be more and there are more chances of death. Second, suspicion or proven malignancy, means any cancer of tonsil, any peritonsillar abscess which is not responding to treatment or it is a bit recurrent. Okay na? Severe dysphagia or speech problem because of tonsillar hypertrophy. So all these are absolute indication. What can be the relative indication? So for relative indication means you can do, but if not urgency you can avoid also. Okay, so recurrent acute tonsillitis. What is the definition for recurrent acute tonsillitis? 7 or more episodes in 1 year, or 7 or more episode in 1 year, or 5 episode per year for 2 years, or 3 episode per year for 3 years. Okay na? So if any of these is given in option, then it is a relative indication. The next, chronic tonsillitis with persistent symptoms which is not responding to medical therapy. Tonsillolithiasis with symptoms, it is a relative indication, and unilateral tonsillar enlargement is also a relative indication. So first option, so tonsillitis more than 5 episode per year for 2 years means it is recurrent. I can do tonsillectomy. Tonsillolith means stones. OSA means obstructive sleep apnea due to hypertrophy. Here also I can do. So the only not a indication is cardiac valvulitis. So cardiac valvulitis are mainly because of streptococcal throat, which will lead to the acute rheumatic fever and causes valvulitis. So if somebody who is having valvulitis, they already develop symptoms, so there is no need to remove tonsil. Second, if somebody who is having valvulitis, our first aim is to stabilize the heart, then only we can do any surgery. Okay, so for cardiac valvulitis, neither it is a indication, okay, nor it is a contraindication. Okay na? So both it is not. Okay, so if you want to know what are the contraindication for uh, tonsillectomy, then they are also absolute and relative. In absolute, we have uncontrolled uncontrolled bleeding disorders like hemophilia, unstable cardiopulmonary diseases like valvulitis, all those. Okay, now but into the acute conditions. Okay, acute infections, poor general health, or any systemic severe illness, these all are absolute. But relative will be cleft palate and age less than 3 years. In all these patients, you will not do tonsillectomy. So, for answer will be cardiac valvulitis, which is neither a indication nor a contraindication. Okay, na? If it is in acute condition, then it can be a contraindication, but not a not in chronic cases. Like somebody who have already developed, no need to do tonsillectomy. Next question is, a 38-year-old woman presents with severe throat pain, difficulty swallowing, trismus. CT next show peritonsillar fluid collection and inflammation. What is the next best step? So this is the classical presentation of peritonsillar. So this is the classical presentation of peritonsillar abscess. Okay. So what is how patient is presenting? Severe throat pain means patient will have severe pain, dysphagia and trismus. Next is, what is the next best step? So in this condition, since in the peritonsillar area we have fluid, so best treatment option will be needle aspiration and antibiotics. Okay, na? Why not tonsillectomy? Because this is reserved for the recurrent cases, or I can say this is reserved for the patients who are having chronic tonsillitis which is not responding to treatment. So recurrent and chronic tonsillitis, if they are having, then I will go for tonsillectomy. Oral corticosteroids I can give, but it can only suppress the inflammation. It will not help me to drain the abscess. Okay, na? So pain will not go away. That's why not the oral corticosteroids. Next one is empirical antibiotics alone. So they can help me treat bacterial infection, but they are also not able to resolve the abscess. Okay, na? So symptoms are mainly because of these fluid collection and all those. So they are, if they are not able to treat, I cannot choose. So first and best initial treatment in this case will be needle aspiration. Then I will send this pus for the culture, and then I can do antibiotics, which will also help me suppress the inflammation also and suppress the symptoms also. So correct answer, needle aspiration and antibiotics. Next question is, 8-year-old boy presents with recurrent episodes of epistaxis. Histological specimen of the excised lesion is shown below. What are the correct about this condition? So in exam you have got these two images. Okay, so this is the histopathological image and this is the gross image. So here you can see the boy with this type of deformity, and in this histological image you can see these are the blood vessels. Okay, na? And here lot of collagen is present and there is lot of fibroblast. So this is the condition called as juvenile nasopharyngeal angioma or angiofibroma. Okay, na? So this is the presentation of GNA. So now you need to search this, that which one is the correct option for this, except means which one is incorrect. So one by one we will go. So first is saying emergency bleeding can be managed by adrenaline soaked gauze. Yes, because if you know, adrenaline is a vasoconstrictor. So in emergency condition we can give gauze which are soaked in adrenaline, which will suppress or which will provide temporary relief until you will make the final decision for his treatment. Okay, na? So until you are thinking for that, till then you can give this, but you need to take care for the hypertension. Second one option is saying frog face deformity can occur in advanced cases. Yes, this is also true. Why this is also true? Because if you know, frog face deformity, juvenile nasopharyngeal angiofibromas or JNA, they have significant tumor extension into the tumor extension and facial bone remodeling which is mainly due to the mass effect, and they are pushing the facial structure forward and outward. Okay na. So this tumor can undergo extension, and it will lead to the facial bone deformities. Okay na, and pull out all the contents outside. So this type of deformity is called as frog deformity, and which is more commonly seen with advanced cases. Next is third option is saying Radkowski stage 3 involves cavernous sinus extension. So here I have added the Radkowski staging. So it has 3 stages. Okay na. Then each stage divided into their sub. So 1A, it is limited to nose or nasopharynx. 1B means one or more sinus. 2A means minimal extension into pterygopalatine fossa. 2B means entire pterygopalatine fossa with or without erosion of the orbital apex. 2C means involvement of infratemporal fossa with or without extension into the cheek. 3A means erosion of skull base and minimal intracranial extension. 3B means erosion of skull base, extensive intracranial extension with or without cavernous sinus. So this option is saying that Radkowski 3 staging is saying cavernous sinus extension is present in 3B. So this is also correct. What is the fourth option is saying Hallman-Miller sign is always present in all cases. So Hallman-Miller sign. What is the Hallman-Miller sign? This is present in CT. Okay, now you will see this in CT. So what this means? That this is the posterior wall. This is the posterior wall of maxillary sinus. So anterior protrusion of the posterior wall of maxillary sinus is called as Hallman-Miller sign, which is not a pathognomic sign. It is seen with it can be present with JNA, but it is not a pathognomic sign, so it can be absent in some patient also. So this is the correct statement. So what you need to remember about Hallman-Miller sign, that it is a supportive sign, but it is not a pathognomic sign. So maybe in some cases they don't have Hallman-Miller sign present. So this is the correct answer. Next is a singer presents with difficulty singing at high pitch. On examination, bowing of vocal cord observed onto the right side. Which muscle likely been compromised? So we will come on to each muscle one by one. So first is cricothyroid. What you need to remember about cricothyroid? What is the function? It is the tensor muscle, and it will elongate vocal cords. Okay na. So whenever I am whenever vocal cord are getting tense and elongated, they will increase the pitch of voice. Okay, who will supply this? So this is supplied by the external branch of superior laryngeal nerve. Okay na. Second muscle is posterior cricoarytenoid. What is the function of posterior cricoarytenoid? This is the primary abductor muscle. Okay na, which will help me open up vocal cord for breathing. Okay na. Next muscle is lateral cricoarytenoid. This is the adductor and rotator muscle. Okay na, it will help adduct and rotate the vocal cords, and this will also help me regulate voice intensity. Okay na. Next is thyroarytenoid. Thyroarytenoid, it will include vocalis also. Okay na. It will help me relax and shorten vocal cords. Okay na. Whenever we are doing this, we are lowering the or decreasing the pitch of voice. Okay na. And so these are the function of muscles, and last these three muscles are supplied by recurrent laryngeal nerve. So if any problem with cricothyroid or any problem with its muscle, patient cannot able to achieve high pitch. So he is having problem with high pitch. Okay, and also whenever you will see in the laryngoscopy, vocal cords will have bowing. Second, cricoarytenoid. If any problem with this, patient will have adducted vocal cords, plus they will have difficulty in breathing because vocal cords is not able to open, so air will not able to pass properly, so they will have difficulty breathing. Lateral cricoarytenoid is for the voice intensity. Okay na? So if any problem with this, patient will have weak breathy voice. Okay na? Weak breathy voice, or I can say labored voice. Thyroid retinoid is for the lowering the pitch. So if any problem, they will have hoarseness of voice. Okay na? Hoarseness of voice, or they will not able to decrease the pitch, all those. So here he is saying he is having problem or difficulty in singing at high pitch and low bowing. So the correct answer will be cricothyroid, which is a tensor and elongator of vocal cords. Next question, a 5-year-old child present with sudden severe ear pain and hearing loss. On otoscopy, you observe hemorrhagic bullae and inflamed tympanic membrane. What is the correct answer? So this image was given. As soon as you will see this image, you can see these are the bulla. Okay na? And these bullas these are the hemorrhagic or serous bulla, which are presented onto the inflamed tympanic membrane. So correct answer will be myringitis bullosa. Why not serous otitis media, and why not acute otitis media, or why not myringitis granulosa? So first I will come on to the myringitis bullosa. So here the bullas are present into there is hemorrhagic and serous bulla present into the membrane, which is pathognomonic. Okay na? Which is pathognomonic for the myringitis bullosa. It is associated with viral or bacterial infection. So influenza virus or mycoplasma pneumoniae can cause this disease. And in this condition, patient will have sudden severe otalgia, means ear pain, and which is associated with hearing loss. Okay. Why not myringitis granulosa? Because myringitis granulosa is a chronic inflammation. Granulosa means there has to be presence of granulation tissue. Okay na? So when you will see tympanic membrane, you will see this granulation tissue. Here you can see this is for myringitis granulosa. In this condition, patient will present with persistent otorrhea. Okay na? Persistent ear discharge, otorrhea, and conductive hearing loss. Next, why not serous otitis media? So serous otitis media is also called as otitis media with effusion, means there is fluid present in the middle ear space, which will lead to the dull retracted tympanic membrane, and inside that you will see these bubbles or ear fluid levels into the otoscopy. So what you will see in otoscopy, either you will see air fluid levels, okay na, or you will see bubbles into the otoscopy, and this is also associated with conductive hearing loss, and patient will have feeling of fullness. Okay, so this is characteristic for serous otitis media. Why not acute otitis media? So acute otitis media classically present with bulging erythematous. Okay na? So bulging erythematous, opaque tympanic membrane. Okay na? Why opaque? Because of purulent effusion into the middle ear, which will also lead to the loss of normal landmarks. And okay, so here you can see the tympanic membrane is bulged out and very opaque. So this is acute otitis media. So in some severe cases of acute otitis media, you can see bulla, but that are not classical. So this picture is classical for myringitis bullosa. So correct answer will be myringitis bullosa. Next question says the following image shows. So this image was given. So we will come on to the one by one option. So first option says vocal polyps. So what are the polyps? These vocal polyps generally are unilateral mass, can be sessile or can be pedunculated. Okay na? And they are larger than nodules, and they have reddish gelatinous appearance. Okay na. So here I have given you the image, and here you can see this is the polyp. So this is not the correct answer. So first option is not the correct answer. Next is respiratory papillomatosis. Respiratory papillomatosis means irregular cauliflower like growth, or I can say multiple bot like growth, which is caused by human papilloma virus. And even if you will remove these, they will again recur. So treatment is also difficult. So here you can see multiple these growth, abnormal growth. This is the correct answer. So answer will be respiratory papillomatosis. Next, why not buccal nodules? So buccal nodules are generally bilateral and symmetrical, and they are present at the junction of anterior and middle third. Okay na. So they are present at the junction of anterior middle third. They are bilateral and symmetrical. They are smooth and small whitish nodules. Okay na. And they are mainly because of chronic abuse of voice. So here you can see these small nodules. These are vocal nodules. So they are symmetrical, bilaterally present, not in this picture. Okay. Next is why not TB or vocal cords. TB generally not present with any of these type of appearance. It is present with ulcerative lesions of the vocal cord, and there can be granuloma also present, and there will be diffuse inflammation, and it can be associated with pulmonary TB. So here you can see unilateral, or one side of the vocal cord is having ulcerative lesion, which is specific for TB. Okay na. So this is how we will get on to the answer. That correct answer is respiratory papillomatosis. And why not the other answers are correct, I have explained you. So next question is 56-year-old patient present with recurrent severe nosebleed from anterior nasal septum. The bleeding has been refractory to nasal packing and chemical cautery. The decision is made to proceed with surgical ligation to control the bleeding. Which of the following artery is the primary target for ligation in the management of patient's anterior epistaxis? So I think everyone know, or most of you know, that anterior epistaxis is mainly because of Kisselbach's plexus, okay na, which is also known as little area. If you know the blood supply of this area, okay na, so major contributor in this area is sphenopalatine artery. Okay na. This sphenopalatine is the branch of internal maxillary artery. Okay na. And or I can say this is the terminal branch of internal maxillary artery, and this will majorly supply the nasal cavity, including the anterior nasal septum, and it is the major contributor of Kisselbach's plexus or little area, which is present antero-inferior to the nasal septum. Okay na. In 90% cases of anterior epistaxis is because of sphenopalatine artery. Okay. So what operation you will do, or surgical you will do SPAL, endoscopic sphenopalatine artery ligation. Okay na. So this is the first line surgical intervention for refractory anterior epistaxis. Okay na. What do you mean by refractory? Means when all the conservative management failed, like packing, cauterizing, you have everything tried, still patient is having bleeding, then you will do arterial ligation, and this is having 85 to 95% success rate. Okay na. And it is the gold standard nowadays. So correct answer will be sphenopalatine. Why not facial artery? So if you know, facial artery will give branch superior labial artery, which will supply the inferior aspect of Kisselbach plexus. Okay na. So inferior aspect of Kisselbach plexus is having superior labial artery, which is the branch of facial artery, and this will provide minor contribution. So that's why it is not the answer. Second, next option, anterior ethmoidal artery. Anterior ethmoidal artery, if you know, it is the branch of ophthalmic artery. Okay na. It is the branch of ophthalmic artery. It will supply anterior nasal cavity. Okay na. Superior anterior nasal cavity and
anterior ethmoidal cells. Okay na? And this is also the minor contributor of Kisselbeck's plexus. That's why it is not the correct answer. If question have mentioned that he is having bleeding in superior anterior or roof bleeding, then this will be the answer. Why not internal maxillary artery? So internal maxillary artery give branch sphenopalatine. Okay na? So why we are not doing this? Because this is reserved for cases where sphenopalatine arterial ligation is failed. Okay na? So this ligation is done when sphenopalatine arterial ligation is technically difficult or has failed. So the operation to ligate this is called as Caldwell-Lukes operation. Okay na? This is a transcentral approach and this is mainly reserved for the severe refractory cases. Okay na? Where sphenopalatine arterial ligation is not successful or has got failed or there are some technical problem, then we can do. Okay, so this is the correct answer. Next question is saying that 35-year-old man present to emergency department with complaint of food stuck in his throat. On examination, you have seen a bone in left piriform fossa. Which of the following is most likely to be impaired? Okay na? So what is piriform fossa? So this is the posterior view of larynx. You can see this is the root of tongue. Okay na? And here we have piriform recess or piriform fossa. If I will do the laryngoscopy, then I will see. So this is the airy epiglottic folds. This is the laryngeal inlet, and near that I have these two spaces. These are called as piriform fossa. So it is located piriform or piriform fossa, whatever you want to do, fossa recess. It is located within hypopharynx. Okay na? So posterior most part of pharynx, here there it is located. It is located lateral to laryngeal opening. Okay na? Okay, and foreign body into this area will directly stimulate gag reflex. Okay na? Patient will have dysphagia. Patient will also feel odynophagia. Okay na? So dysphagia means difficulty in eating. Odynophagia means whenever you are swelling you will have pain. Why gag reflex? Because this area is innervated by two nerves. So afferent innervation and efferent. Afferent is by the glossopharyngeal nerve. Efferent is by the 10th cranial nerve. So gag reflex will be stimulated. So correct answer will be gag reflex. Now why not cough reflex, salivation or mastication? So if you know, cough reflex is mainly mediated by the vagus nerve. Okay na? And this is mediated by the vagus nerve in larynx below the vocal cord, in the trachea and in the bronchi. So whenever we have any foreign body in larynx or in trachea, then the correct answer will be cough reflex. Why not salivation? Because it is by the parasympathetic nervous system. Okay na? So if you know, submandibular and sublingual by the facial nerve, parotid by the glossopharyngeal nerve. Okay na? So if any problem with parasympathetic nervous system, then patient will have salivation problem. Why not mastication? Because all the muscles of mastication are supplied by trigeminal nerve, and in this condition patient will have problem with chewing. Okay, so since they are saying that he is having problem body or foreign body in piriform fossa, in piriform fossa gag reflex is mediated. That's why the correct answer will be gag reflex. Next is a patient present to the emergency department with significant nasal trauma after a fall. Examination revealed deviated nasal pyramid. Palpation confirms crepitus and mobility of the nasal bone. On lateral nasal bone X-ray confirms displaced nasal fracture. Which of the following instrument is specifically designed for the closed reduction of the displaced nasal fracture? Okay na? So here I have added all the forceps used in ENT and ENT. Okay, so first is S septum forceps. Since it is saying septum, so this is used for the septal fracture reduction. Okay na? Next is valsum septum forceps. Okay na? So this is for balsam septum forceps is for the close reduction of nasal bone fracture. Okay na. So here we need close reduction for displaced nasal fracture. So correct answer will be balsam forceps. Next is given forceps is Luke's forceps. Why we need Luke's forceps? To remove any nasal polyp. Okay, so we will use this for removal of nasal polyp. Any bits of bone during the surgery we can remove, or any tissue dressing, tissue surgical dressing or anterior nasal. For all those we are using Luke's forceps. Next given is Tilley's forceps. Okay na. Tilley's forceps also used for the nasal packing. Okay na. It is also used to remove foreign body. Okay na. And it is also used for the deep nasal dressing. Next given one is bayonet. Okay na. Because of this angle, our hand will be away from the surgical side, so we will have better view. So this is also used for the foreign body removal. Okay. Next is this one is called as crocodile forceps. Okay, so this is also known as crocodile, or somewhere it is written as alligator forceps. Okay na. So crocodile, alligator forceps. So where you will use this? This will also used to remove foreign bodies, but this one because of the hook present in the uh, starting part, this is used for the removal of foreign body in child. Okay na. So this is crocodile, and crocodile forceps is also known as Hartmann forceps. So this will also used to remove foreign body in kids. Okay na, because of this part. So you can easily hold the foreign body and remove. Next one is Jensen Middleton forceps or JM forceps. This is to use cutting, okay na, because of its ends, cutting or removing any bone or cartilage. Okay na, especially nasal and sinus surgeries. Last one is called as Black Sally forceps. Okay na, this is used for the endoscopic surgeries. Okay, so this is used for the endoscopic sinus surgeries for grasping or removing any tissues. So these are all the forceps. So since it is asking about close reduction forceps for the displaced nasal fracture, correct answer will be Waltham forceps. Next is 50-year-old female complain of episode of an acute vertigo with vomiting, unsteadiness, lightheadedness, which is triggered by changing her head position in the morning. She denied hearing loss, recent viral illness, medical use, head injury or trauma. What is the appropriate diagnosis? Okay na. So whenever they will mention you, okay na, so in question they have mentioned that she is having acute vertigo, okay na, with vomiting, unsteadiness, lightheadedness, which is more in positional changes. Okay na, and there is no history of hearing loss. This is classical for the BPV, benign paroxysmal positional vertigo. Okay na. So when you will see BPV, so in BPV you will have positional vertigo, you will have mixed nystagmus which are torsional and vertical, and mostly these episodes will last less than 1 minute, and these are mostly occur when the patient is changing the position, and there will be no hearing loss. In this condition, what will be the diagnosis? First, the classical symptom. Also you can do test called as Dix-Hellpike test, okay na, or maneuver. So this is diagnostic, and for the treatment you will use Epistaxis maneuver. So here you can see this is the Epistaxis maneuver. Why patient is having this? Okay na. So BPV is because of dislodged or dislodged autoconia, okay na, disclosed otoconia which are floating in semicircular canals. So because of their movements, patient is having vertigo. Okay na? And whenever they have given that there is no history of hearing loss, no viral, no medication, no head injury, nothing, only vertigo with positional changes, then it is surely BPB, means benign paroxysmal positional vertigo. Okay, now why not vestibular neuritis? So in vestibular neuritis, if you know, they have single severe prolonged attack of vertigo. Okay na? So they will have severe single and prolonged attack of vertigo which can last for days. Okay na? So this will be present for days, and it is mostly preceded by or caused by any upper respiratory tract infections or any viral syndromes. Okay na? And here vertigo will be constant, it is not changing with the, or it is not occurring because of positional change. What is Meniere disease? So classical triad of Meniere disease is episodic vertigo. So vertigo will come in episode. Then there will be fluctuating sensory neural hearing loss, and along with this patient will have tinnitus. So this is the classical triad of Meniere's disease. Okay na? And in this condition episode can last from minutes to hours. Okay, why not acoustic neuroma or vestibular schwannoma? So this is the cancer. So in this condition they will have slowly, or I can say gradual progressive, okay na, gradual progressive unilateral, whichever side is affected they will have that side, or it can be bilateral also, unilateral sensory neural hearing loss and tinnitus, and which can be present from months to years. So that's why this is also not the answer. So whenever they will mention positional changes or because of position changes they are having vertigo, then it is surely BPBV they want to ask you. Next is tuberculous otitis media of the middle ear has all of the following except, means which one will be absent in this condition. So if you know TB, okay na, TB is a chronic condition. Okay na? So whenever TB is occurring into the ear, it is occurring slow and gradually. Okay na? And if you know in TB we have read that there will be granulomas. Okay na? And because of these granulomas they will have osseous erosion. So this option is correct, means this is the feature of tuberculous otitis media. Patient should be started on ATT. Yes, because he is having TB, I have to give anti-tubercular treatment. There will be multiple perforation onto the tympanic membrane. Yes, okay na. So all these, because of these TB they will have multiple perforation, which is a classical sign. Okay, and these perforations are small and non-healing perforations. Okay na, and they are the reason patient is having chronic discharge. So all three are correct. So okay, so which one is not the correct option in out of these? That will be our answer. So correct answer in this question will be our option B. So why B? Painful ear discharge are seen. No, it is a gradual process, so generally it is a painless. Okay na, so painless discharges are seen, or I can say painless otorrhea is seen. So it is an insidious slow growing infection, that's why they don't have pain. Okay na, so this is the correct answer. Next is which of the following statement correctly defines Trotter's triad? So Trotter's triad you will see in nasopharyngeal carcinomas. Okay na, so what is the classical triad of Trotter's? The patient will have conductive hearing loss, they will have trismus, or which is also called as restricted mouth opening. Okay, or this is also defined as ipsilateral temporoparietal neuralgia. Okay na, so first will be conductive hearing loss, second part of the triad will be trismus, restrictive mouth opening, or ipsilateral temporoparietal neuralgia, and third will be palatal anesthesia or palatal paralysis. Okay na, So why Trotter's triad is occurring? Because of extension of nasopharyngeal carcinoma. Okay, so conductive hearing loss is because of blockage of Eustachian tube. Okay, na? These all features are because of trigeminal nerve involvement. Trigeminal nerve involvement, and palatal paralysis is because of vagus nerve involvement. So now we will read one by one option. So first option is saying conductive hearing loss, trismus, palatal anesthesia. Okay, we will read more, then we will come to the answer. Sensory neural hearing loss, trismus, palatal, no, it is conductive hearing loss. Conductive hearing loss, trismus, facial pain, palatal anesthesia. Okay, this is also not the correct answer. Okay, na? Conductive hearing loss, trismus and nasal obstruction, this will also not be the answer. So correct answer will be conductive hearing loss, trismus and palatal anesthesia. So this is the correct answer. So this is about Trotter's triad. Okay, next question is related to TNM staging. Okay, so 62-year-old male present with progressive hoarseness, mild dysphagia for 4 months. Laryngoscopy says lesions are seen involving both vocal cords with impaired mobility but no fixation. Reveals single firm non-tender lymph node measuring 2 cm in diameter in the right cervical region. No distance metastasis is seen. So what it will be the TNM staging. So if you know laryngeal carcinoma, TNM staging divide into 3. Okay, na? Supraglottic carcinomas, glottic and subglottic. Okay, na? So here is the full list. If you want to read, I have made it easy so you will understand. Okay, so T is for the tumor size and extension. So for all these three, what will be the T1? Small, limited to one area, normal function means only one vocal cord involved, normal movement. Okay, na? Since in question they mentioned both vocal cord involved, so means this will not be the correct answer. Second, T2, bigger, involves more than one area or function impairment means both vocal cords and impaired in movement. So both vocal cords and impaired mobility means this is correct, but no fixation. Okay, na? So here you can write no fixation. T3 means even bigger, function is totally lost. Now they have vocal cord fixation and invasion to nearby spaces. T4 means invade outside the organ means cartilage or nearby tissue. What is N? N for the lymph nodes. So N0 means no lymph node involvement. M1 means single small same side ipsilateral and less than 3. So in question also they mentioned 2 cm and the right side non-tender single. So then this will be our N1. N2 means multiple lymph node medium and mixed-sided 3 to 6 cm or they can be bilateral. N3 means giant lymph node more than 6 cm. Okay, M0 no distant metastasis, M1 distant spread. So here it said both vocal cords with impaired mobility and no function means it is T2. Node is single non-tender less than 2 cm and right side means it will be M1. No distant metastasis means M0. So correct answer will be A. Next question, which of the following structure are typically visible during the indirect laryngoscopy? So you need to remember that in indirect laryngoscopy we cannot see subglottic region, we cannot see tracheal ring. Okay, na? So these will not be the answer. So what will be the answer? We can see epiglottis, we can see arytenoid cartilage, we can see true vocal cords and we can see posterior pharyngeal wall. So answer will be A, B, C and F. So answer will be B option or second. Okay, na? So for this you can remember one mnemonic: every amazing vocalist performs. So E for epiglottis, A for arytenoids, B for vocal cords, that is true vocal cords, and P for posterior pharyngeal wall. So these are the all questions related to ENT. Okay, thank you very much, and if you have any doubt please do comment, we will reach out to you. And if you like this discussion, please like, share and subscribe. Thank you.